you all from wherever you're joining. My name is Dr. Hassan Datu Mohammed from Aminu Kano Teaching Hospital, the president-elect of the Nigerian Society of Anaesthetists. You're most welcome to this webinar, which is the session number 8, series 6, session number 8. Without wasting time, because we have reached 50 already participants, so I will hand you over to the moderator, Dr. Ekene Omo, who is a consultant anesthetist and chairman, Medical Advisory Committee, Federal Medical Center, Asaba Delta State. Over to you, Dr. Ekene. Thank you.
Good evening, everyone. I guess we are all currently muted, so we won't be getting much of responses from us right now. But I want to welcome us to this webinar series. Please permit me, let me share my slide before I start. Wait just a minute.
You're having difficulty sharing?
Yes, I don't know why.
So maybe you can just briefly introduce him and we'll move, yes.
We'll move ahead. I'm surprised.
Later at the end, we can share that one, even when he leaves. Okay, thank you.
All right, okay. It is an honor to introduce our speaker for today's event. His name is Professor Mahmood Sani. He is a professor of medicine from the Bayero University, Kano, Nigeria. He is currently the Deputy Vice Chancellor, Management Services, Bayero University, Kano, and he's the chair, Pan-African Society of Cardiology Task Force on Research and Training, and an examiner to the West African College of Physicians since 2008. He is a World Heart Federation emerging leader from 2015. Professor Sani Mahmood has published over 120 peer-reviewed scientific papers, including co-authorship of manuscripts in the New England Journal of Medicine, the Lancet Circulation, Heart, European Heart Journal, and European Journal of Heart Failure, amongst others. You will agree with me that we'll be expecting a lot of stuffs or a lot of academic knowledge will be passed across this evening that will help us better manage our patients. So Prof, sir, the floor is open to you, sir.
Thank you very much, Dr. Ekene, for the kind introduction. I'm really humbled by the introduction. I don't know if you can see my slides.
Yes, we can see.
Okay, so I want to start by thanking the Dr. Detti for inviting me to this presentation. I feel really honored to make this presentation to a very esteemed group of this very important society. I have made similar presentations to the Department of Anesthesia in my hospital and university in previous years. So that's why he asked me to make this presentation. So I'm going to go through it. It's have in slides, I will be quite rather fast period of time. Also see it as an opportunity because many of you may even know ECG better than I do. So it's a chance to share knowledge and then discuss issues on this ECG interpretation. So what we're going through is what is an ECG? So ECG is the E is electroactivity, the C is cardio, and the G is ground, with essentially recording of an electrical activity of the heart. It is also a time voltage tracing that shows the activity of the heart electrically viewed from the surface. Therefore, the tracing we see on each lead actually represents the tracing of the activity of the heart viewed from that lead. If you have a lead on the right shoulder, then whatever you are seeing on that lead is the activity of the heart electrically viewed from the right shoulder. If you have a lead on the left foot, whatever you see is the activity of the heart electrically viewed from that left foot. It's a very simple investigation that has stood the test of time. It's been around for more than 100 years. And despite the advancement of cardiology and cardiovascular investigations, ECG remain very relevant to our diagnostic procedure and day-to-day management of patients. So the basic principles, as we know, the principle of action potential is that at rest, the heart cells are polarized and the interior is negative. And when they are stimulated, they can depolarize and they become positively charged, and then they contract. After contraction, then they repolarize and they regain their negatively charged in the interior. Now, the basis of the action potential is the basis of the ECG, and these waves of depolarization and repolarization are the ones that we see on the ECG when we put the leads on the surface and we see them. And whatever activity, mechanical activity of the heart we see, it's actual translation of the electrical energy to mechanical energy. Without the electrical activity that starts from the SA node and spreads across the heart, there will be no mechanical activity. So it's really important to appreciate that this electrical activity we see on the ECG, the one that initiates even the contraction that we see of the heart and the systolic function that the people have and remain alive. Now, it's important to also understand the cardiac conduction system. As I mentioned earlier, the SA node, the pacemaker of the heart, it has the lowest threshold for initiating activity electrically. And then the impulse starts from the SA node, spreads to the atria through the intraatrial pathways. And then it is the AV node, whether it's late for some time. From the AV node, which is located in the AV junction, is going to the bundle of his, and the bundle of his divides into two, into the left bundle branch and the right bundle branch. And then the left bundle branch also divides into the left anterior fascicle and the left posterior fascicle. And then the right bundle branch doesn't divide into any branches, it's a single one. And then all of them now have small branches called the Purkinje fibers. So the impulse starts from SA and spread across this pathway to the heart. And this is what leads to the simultaneous contraction of the heart by the spread of this impulse across these fibers. So it's important to understand this conduction pathway because it's important in understanding the ECG interpretation. Now, the ECG has waveforms and intervals. We have the P wave, we have the PR interval, we have the Q wave, we have the QRS interval, we have the J point, which is the junction between the S wave and the ST segment. We have the SE segment, the T and the U wave. And then we also have the QT interval. Now, the P wave signifies atrial depolarization. And then the QRS complex signifies ventricular depolarization, while the T wave signifies ventricular repolarization. You will see that the atrial repolarization is not depicted on the ECG. It's because the time it takes for the atria to repolarize is so short that is to be depicted on this surface ECG. But if you do a more advanced ECG, like a His-bundle ECG, you'll be able to see and measure the period of atrial repolarization. The ST segment represents the period whereby the ventricular remain depolarized, at which time, unless you have a very strong impulse, they will not be depolarized again. So this is, and the QT interval signifies the times that it takes for the ventricle to actually, it depicts the QT interval depicts the time it takes for the ventricular to get both depolarized and repolarized. Now, these terms, repolarization and depolarization, it can also be synonymously used with activation and relaxation. Well, that is, they're all electrical terminologies. But when you come to mechanical terminologies that mirror this image, depolarization is synonymous with contraction, because that is when they contract, or systole, while repolarization is relaxation or diastole, just to clarify. Now, the ECG has a lot of uses. It's used for the identification and diagnosis of so many things, from identifying the axis of the heart, that is how the electrical resultant vector of this activity is oriented in the heart or in the chest, to identifying the heart rate, to getting various problems with activation sequences, effects of drugs, effects of electrolytes, inflammation of both the pericardium and the myocardium, to signs that would detect whether there is ischemia or infarction, arrhythmias, atrial enlargement, or ventricular hypertrophy are all things that you can see on the ECG. The ECG also not give you an etiological diagnosis in most circumstances, but it will show you, it will give you a lot of guidance as to what is happening to the heart electrically. Now, there are many types of ECGs, and I'm not going to spend time on this slide. The standard ECG is the 12-lead type of ECG, which we all know, and we use it in our day-to-day activities. So just to mention that the other forms of ECG, including the stress ECG, the Holter 24-hour ECG, the so-called ECG jacket, when you have 100 leads spread across the whole of the chest, as well as telemetry that you are very familiar with, that we use in monitoring of patients in ICUs and CCUs. Now, the recording of the ECG is important because it's recorded with standard paper at a standard speed with standard calibration. So we make sure that there's effective contact between the electrodes or the leads and the skin, so that we don't have artifacts on the ECG. The ECG is recorded as a calibration of 10 millimeter or 10 millibar. I'm going to show you a slide on that. And the speed is important also to note that it's a standard speed of 24 meters per second. And this is the base on which we are doing the heart rate. We use the number of squares to divide by the particular number to get the rate, the heart rate. I'm going to also briefly mention. And then a recording that could be artifact that could be external or internal. And if you have somebody that is shivering or have tremors, you have external artifact, or you have some issues with the currents, line currents, you have internal artifacts. Also note that when you have an impulse moving towards a lead, it gives you a positive deflection. And you have an impulse moving away from a lead, it also give you a negative deflection. This is also a standard rule in ECG interpretation. And this is just a picture to show what I just mentioned about the positive deflection and the negative deflections. Now, the ECG paper is a standard paper, it's universal. Even though now we can print ECGs on A4 on some machine, but even then, it still comes out with the standard tracing of the ECG paper. Now, the ECG paper is made up of small squares and big squares. The small squares are 5 millimeter by 5 millimeter, and each 1 millimeter square represents 0.1 millivolts. Then the big squares, so the small squares are 1 millimeter by 1 millimeter. Now, in terms of the seconds, the ECG, the paper I mentioned earlier is a voltage against time tracing. So on the voltage, on the y-axis, every 1 millimeter is 1 millivolt. Now on the x-axis, every 1 millimeter is 0.04 seconds. And this is because the speed at which the ECG tracing is done is as 25 millimeter per second. And if you do 1/25, you get 0.04 seconds. So every 1 millimeter on the x-axis is 0.04 seconds, and 5 millimeter on the b square represents 0.2 seconds. Now, the ECG leads electrodes which measure the difference in electrical potential between either two different points or one point on the body and a virtual reference point with zero electrical potential located in the center of the heart, which are unipolar leads. So we have chest leads and limb leads. We have 3 standard limb leads and 3 augmented leads and 6 precordial leads. The 3 standard limb leads are actually bipolar leads because they measure differential difference between 2 points. I'll show you later. While the 3 augmented leads located on the right shoulder and the left shoulder and the left foot, they are unipolar leads. And they measure points between that point and the virtual point at the center of the heart. And all the precordial leads are actually unipolar leads also. Now, I mentioned this point also, the lead represents viewpoint, and the leads lie, limb leads lie in the frontal plane. So they look at the heart from the coronal plane, while the chest leads cycle the heart, the transverse plane. Also, it's put into consideration. So the standard limb leads are lead 1, lead 2, and 3. And we see that lead 1 measure potential between the left arm and the right arm, lead 2 between the right arm and the left leg, and lead 3 between the left leg and the left arm. And so these are actually bipolar leads. And so it's important to note that this triangle represents the Enthoven triangle. Enthoven is the first man that described the ECG. And mathematically, because this triangle is an equatorial triangle, every angle here is 60 degrees, which makes the angle of the triangle as 180 degrees. So mathematically, this triangle can be represented in this form with this line representing the lead 1, this line representing lead 2, and this line representing the 3, so long as the angles between them are all 60 degrees. So this is very important because when we're going to do the cardiac axis, we have the hexagonal reference system which we choose, and it's based on this principle. So this Enthoven triangle is the one that we actually transform into this angle mathematically, into this diagram mathematically, because the angles between these leads are all 60 degrees. And so if you put you consider now the augmented leads, which are the AVR, the AV, and the AVR, you see that this is on the right arm, left arm, and left foot. And this is how is it. And if you add all of them, with the 6 leads that are the limb leads, you have what you call the hexagonal reference system. Just note that the between lead 1 and AVF is 90 degrees. Between lead AVL and lead 2 is 90 degrees. Between lead AVR and 3 is 90 degrees. So we have now transformed the original Enthoven triangle into a hexagonal system, adding the augmented leads. And this is what we use to calculate the cardiac axis, which we will see later. Now, the precordial leads are placed in the chest. The first lead, B1, on the right intercostal space, right fourth intercostal space at the sternal margin. B2 is at the same fourth space on the left side at the sternal margin, and B4 is the fifth space at the midclavicular line. B3 is between the two, that is B2 and B4. B5 is also the same fifth space, but now anterior axillary line, and B6 is at the same fifth space, but in the mid-axillary line. So this is how the leads are oriented on the chest, and everyone of us should know how to put these leads, because we need to learn how to do the ECG ourselves. Sometimes at emergency, we have to put the leads and do the ECG to interpret and help the patient. Now, I've already mentioned this, but just to stress that wherever the lead is placed, what you see on that lead is the viewpoint of that of the activity electrically from that point. So also add the fact that if the impulse moves away from the lead, it gives a negative deflection. So the lead that is on the right shoulder or right arm is looking at the heart from the above, and all the impulse that arise from the SE node will certainly move away from it. It spreads in the downward direction. And therefore, every time the AVR is always negative. If you see an AVR that is positive, so it's either the patient has an extreme right axis deviation or the patient has dextrocardia, in which case you see the impulse will be looking towards the right shoulder. The same thing if you look at the lead on the left foot, which is looking at the heart from below. So whatever you will see on that lead, you see that the impulse will be moving towards it. And so AVF is always negative unless you have an abnormality when it can be negative. Now, this is just to show you how that is oriented in the chest and the leads that look at the heart at different directions. So you see that the anterior part of the heart is looked by B1, B2, B3, and B4. These are anterior of the heart. While the lateral view is depicted by AVL, lead 1, B5, and B6, while the inferior part of the heart is looked by 3 with ABF and lead 2. And this is important because we want to look at localization of impact. The abnormalities you see in the leads looking at the heart in the wall affected. Of course, you can see also reciprocal changes in other leads, but the primary leads that you see the abnormality or the primary abnormality are the leads looking at the particular wall of the heart that is either infected or is ischemic. That's why I put this particular slide. So the intervals also, the mentioned earlier, they have a particular ranges. The pair interval is normally 3 to 5 small squares of 0.12 to 0.2 seconds. You recall that I mentioned every small square is 0.04. So 3 small squares is therefore 0.12 seconds. The QRS complex should be between 2 and 3 small squares. These are important because if you don't know the normal, then the abnormalities cannot be interpreted. The AC segment also should be isoelectric, and then the T wave is a small negative deflection. Sorry, occasionally you can see a negative wave. You can see a negative wave, but usually the T wave is also upright and rounded. Now, reading the ECG. So this particular method I want to share with you. Of how to read the ECG, but it's not cast on stone. Everyone can define how he wants to read his ECG, but it's advised that you need to be systematic so that you don't miss abnormalities when they are around. Now, this particular method follow the ECG waves, and so if you look at them individually and know how they should be normally, then when they are abnormally, be able to identify them. So the first thing to look at anytime you're in an ECG is to look at the ECG calibration. And what is the ECG calibration? The ECG calibration is actually a rectangular tracing that you see at the beginning or at the end of the tracing. So this rectangular tracing is what we call the calibration. And the standard calibration is 10 millimeters, all right? So every one small square is 1 millimeter or 1 millivolt. So the standard calibration of ECG is 10 millimeters. Sometimes if you have a patient with very high voltages, so you see that the tracing overlap each other. So you can have the calibration and do the tracing as half calibration at 0.5, so that you can be able to read the ECG well and then multiply whatever you see in terms of voltage by 2. Or sometimes you see the ECG tracing is so small that you cannot read very well. So you double the calibration and make it 20 millimeters or 2 centimeters so that you can read the ECG. And then when you are interpreting, you take into consideration that you have doubled or you have the calibration. So if you see any ECG without this calibration mark, then that ECG may be very difficult to interpret because you don't know whether it is done at standard calibration, at half calibration, or at double calibration. So this is a clean one with standard 10 millimeters calibration. And so whatever you will see on this, the voltage is what you measure, not half, not double. So this is important, and the first thing that we should look at when you're doing any interpretation. The next thing is the rate. Now, in interpreting the heart rate, it's important to also consider the rhythm, because if the heart rate is regular, then the heart rate calculation will be much easier than if it's irregular. The method we use for calculating the heart rate is different depending on whether the rhythm is regular or irregular. So, but we check first somebody with a regular rhythm. So I mentioned that every small square is 0.04 seconds. Every big square is 0.2 seconds. Now, what we need to find out is how many big squares you need to have 1 minute, which is 60 seconds. So mathematically, you need 300 big squares to get 60 seconds, because 0.2 times 300 is 60. So to calculate the heart rate in a regular, somebody with regular heartbeat, is you find the big squares between the RR intervals, and whatever you find, you divide by 300, 300 over that number, and you get your heart rate. So this patient has 3 big squares between their intervals. So the heart rate is 300 divided by 3 to get 100. Now, sometimes you don't see the RR interval, the stressing falling on the RR interval. So it falls outside that interval. So in that case, you use 1,500 over the number of small squares. And the reason is because every small square is 0.04 seconds, and you need 1,500 small squares to have 60 seconds. So if you have RR interval not following exactly on the big grid line of the big square, then you use small squares and you do 1.5 divided by the small squares to get the heart rate. Now, if the heart rate is not regular, then sorry, before I go, so some standard. So 3 small squares is 100 beats per minute. If you have 4, it's 75. If you have 5, it's 60. If you have 6, it's 50. This is just simple mathematics. Now, if the heart rate is not regular, then in that case, you cannot do this method. What you need to do is to get a long rhythm strip, and you count maybe 30 big squares. 30 big squares is so 0.2 times 30, which is 6 seconds. So you get a long rhythm strip of 30 big squares, and you count the number of QRS complexes in that 30 big squares, and you multiply by 10. You get it for the rate 5 minutes. So if it's regular, it's simple just to get a rhythm strip that is containing 30 big squares, and you count the number of QRS complexes in that strip with 30 big squares, multiply by 10, and you get the rate per minute. Now, to get the rhythm this means that whether the heart is regular or irregular. But just note that the heart pumps blood at a fixed rate, and that is why your heart rate and pulse should be regular. And this helps maintain a constant cardiac output. And then you have mentioned the picturesque waves of the ECG. Now, sometimes the heart rate is not regular or the pulse not regular. If it is regular, it's regular. If it's irregular, then the irregularity could be irregular. In which case, we call it as an irregularly irregular pulse, or the irregularity could be regular, which is called regularly irregular pulse. And a typical example of an irregular heart rate is atrial fibrillation, whether you have actually literally chaotic heartbeat because you have the irregularity in rhythm and volume, and the heartbeat is completely irregular. But sometimes you have irregularity that is regular. Yeah, if you have sudden arrhythmia, for example, because sudden arrhythmia is variation of the heartbeat with respiration. Or it also have a second key heart block that comes in the regular pattern, like Wenckebach phenomenon. You can also have an irregularly irregular pulse. So I think I just put this because of the fact that your specialty is involved with a lot of reading of ECGs in the ICU, the CCU, the monitor. And often what we get, we don't have complete complement of all the 12 leads on the ECG. You have a rhythm strip. So I feel that we can just go through 2 slides on how to read a rhythm strip. First is how is the patient? And this is very important. Always treat the patient, not the monitor. This is echoed by all our teachers. If you have a patient that it's ICU, and you look at the patient first, how the patient is doing, because you may need to act fast to save his life. So it's very important to stress this point. How is the patient before you consider the monitor? The second thing is there any activity electrically? So if you see deflections above or below the isoelectric line, that means there's activity. But it does not mean if you have activity electrically, it doesn't mean necessarily that it's also mechanical activity, because you could have electromechanical association, or what we now call pulseless electrical activity. So it's important to put other in your mind. But first, look at the patient. Then do you have any activity electrically? Then look at the ventricular rate. This is very important. Often when we have arrest, what we have is either a VT or a BT or a BF. So important to look at the QRS rate. And then look at the rhythm of the QRS. Is it regular or irregular? And this is very easy to measure. If I ball in it, you actually look at two consecutive R waves and make a match on the paper, and then shift them to see if they also measure onto the next two R waves. So that is important. The next thing is look at the QRS width. It is normal or prolonged, because we know that if you have tachycardia, if you have supraventricular or ventricular, and the QRS duration determines to some extent whether it's an SVT or a VT, even though we know that we can have SVT with aberration, when you have an SVT with a wide QRS complex. And we also have already mentioned that the QRS should be less than 0.12 seconds or 3 small squares. The next point is if there is any atrial activity on the ECG. If so, is there a normal Q wave or is there a normal Q wave? A normal Q wave is usually upright and then it's rounded in most of the dates. And then lastly, the point is what is the relationship between the activity of the heart, the atria, and the activity of the ventricles? So if there are a P wave for every QRS, with the PR interval within normal limits, and if there are abnormalities, it will really help you looking only at the rhythm strip to determine what the patient is likely to have and what you need to do at that point in time. So quickly to go to issue of rhythm, about rhythm, the specific rhythms. The normal, the sinus rhythm, the characteristic is that the P wave are similar. The ratio of P to Q is 1:1. The rhythm is regular for both atria and the ventricles. The rate is between 6 and 100, and the pair interval are all within the normal range. So this is very important to know that this is a normal sinus rhythm. And this is how it looks like on the ECG. You see that every P is followed by QRS. The P are all similar. The QRS are all similar. And the interval between the RR are the same. And everything is fine. This is a normal. And the rate, this rate is about 70 something, okay? Because it's almost a little more than 4 squares between the RR interval. So sinus bradycardia is just like sinus rhythm, but the only difference in the rate is rhythm 60 beats per minute. But even the intervals are normally except QTC, which could be increased. And there's several courses which I don't want to discuss. I just put them in slides so that you can look at it later to see examples of courses of sinus bradycardia. Now, sinus tachycardia is also similar to sinus rhythm, except that the rate is more than 100, and specifically 100 to 150 is more than 150. Then we probably think about an SVT. So everything is the same. Also, the duration except the QTC could be decreased, and this is understandable, and that's why when you do the QT, you have to correct it based on the heart rate and to get the QTC using the Baz's formula or other formulae. So there are also causes of sinus tachycardia there, and also just to look at them later because of time, we will not discuss them. Sinus arrhythmia I already mentioned earlier. Sinus arrhythmia has P wave to QRS complex, but the issue that the RR intervals are not the same. If you put a paper and mark here between this and this, if you interpose it on the other R, you see that there's different. Compare this one and this one, you see that this is wider. So this is a normal variant. Usually you see that with respiratory variation, and it's common in children actually. It's not as common as in adults you see in children. So this is sinus arrhythmia. Now, SVT is supraventricular tachycardia. It's usually the rate is this one is almost little less above 150 because it's little less than two small squares is 150. But this one is little less than 2 small squares. So you see that it's quite fast and it's narrow complex. So it's really arising from above the ventricles or from above the AV node. So we quickly move to the electrical axis, which is it's usually also done when we are reading ECGs. It's important. It shows the orientation of the overall direction of the heart's electrical activity. Normally, we use the QRS complex to calculate the axis. The normal axis, abnormalities of the axis can hint as to whether you have ventricular enlargement or conduction abnormalities. So I'm going to discuss axis a bit detailed because it's people usually find issues with axis population. So by consensus, the normal axis is between -30 to +90, while the left axis deviation is from -30 to -90, while the right axis is +90 to +180, and while the northwest quadrant, where when you have any axis falling on that quadrant, we call it indeterminate axis or honest axis, and it's usually in very severe heart conditions. So there are 3 ways that we can use to determine the axis. We have the first one is a quadrant approach. The second one is the phasic approach. The third one is the 3-lead analysis. Now, first I want to mention that when you have any the R equal to the S, that we call it an equiphasic lead. And so it is important for axis calculation. So the quadrant approach is the one that I'm going to discuss first. So what we do is traditionally we use lead 1 and ABF. I mentioned earlier that lead 1 is perpendicular to ABF in the orientation of the hexaxis reference system. And so you look at these 2 leads, and if lead 1 is positive and lead ABF is positive, then the axis belongs to this quadrant and is a normal axis. If lead 1 is positive and lead ABF is negative, then the axis is under this quadrant is a left axis deviation. If lead 1 is negative and lead ABF is positive, then the axis belongs to this quadrant and is right axis deviation. And then finally, if all lead 1 and ABF are negative, then the axis belongs to this quadrant and it is indeterminate axis. Now, this method can only allow you to mention whether it is normal axis, left axis, or right axis, or indeterminate, but it won't show you the particular degrees to which the axis is deviated. So this is a very simple and it's quite useful in determining crudely the axis that is normal, left, or right axis deviation. If you have a left axis deviation, that is lead 1 is positive and lead ABF is negative, then to determine whether, because sometimes you could have normally, you could have it in normal people. So particularly when you have left axis deviation, again, look at lead 2 and look at the QRS. If it is positive, then that LAD is non-pathological. If it's negative, however, then it's pathological. So this is very important also for this quadrant method. Now, the next one is the equiphasic or isoelectric approach. This method uses 3 steps. The first step is to identify the lead that is equiphasic. We also call it transitional lead, when the positive and the negative are almost equal. And so if you understand that, if you find, and you use, for this method, you only use in fact, for axis generally, you only use the limb leads. lead 1, lead 2, lead 3, AVR, AVL, AVF. So if you look at the ECG, these 6 leads, which one is epiphasic or transitional? Now, whatever lead you find, the axis is orientally perpendicular to that particular lead. There is a way to read, but I know it's difficult to explain, but it's just showing that the resultant vector usually moves towards a lead that is perpendicular to the lead with almost 0 deflection or minimal deflection. That is what it means. So first identify the lead that is epiphasic, and whatever you find, the axis is along the lead perpendicular to it. And we know that lead 1 is perpendicular to AVF, lead 2 perpendicular to AVL, and lead 3 perpendicular to AVR. So using this, you can identify along which lead you have the axis. So if, for example, you look at the 6 leads and you find that the epiphasic lead is lead 1, for example, let's use this one. Its AVL is the epiphasic lead. So we know that lead AVL is perpendicular to lead 2. So look at lead 2. If lead 2 is positive, then the axis is along lead 2. If, however, lead 2 is negative, then the axis is opposite lead 2, so that the complementary axis should add 180 degrees, because the axis on a straight line, the angle of a straight line is 180 degrees. So let's take this one for example. So this one, AVL is almost the isoelectric lead or the epiphasic lead. So we know that AVL is perpendicular to lead 2, and in this ECG, lead 2, lead 2 is positive. So therefore, the axis is along lead 2 is 60 degrees. If, however, in this lead, it is negative, then the axis is perpendicular to this, which is minus 120, which is indeterminate axis. So this is the isoelectric method, and it's very easy. 3 steps. 1, identify the epiphasic lead, and whenever you find your axis is along the lead that's perpendicular to it, and then look at that lead. If it is positive, it's along that lead. If it's negative, it's opposite that lead. And whenever you find, they must complement 180 degrees. If you find, if you find the lead along lead 2 is plus 60, if it is opposite lead 2, if it's negative, then it's minus 120. And this is how you identify with this method. The last method is the 3D analysis. And this method, you use lead 1, lead 2, and lead 3. And it's quite easy. And so normally, if the patient is normal axis, lead 2 will have the most positive deflection, and all of them will be positive. And that is the normal axis. If the patient has left axis deviation, then lead 2 and lead 3 will be negative, and lead 1 will be positive. This is also a bit crude, but it's giving a little guide. And then the last one is right axis deviation, in which lead 1 will be negative, lead 3 will be positive, and lead 2 may be in between. So these are the 3 methods you use to identify the cardiac axis. And if you go through it carefully, it's really very, very simple, using either the 3D analysis, the basic, or the quadrant method. So we'll quickly move. These are the causes of the various abnormalities. I also jumped them. We can read them later. To abnormalities of specific waves of the ECG. So the first wave is the P wave, and we mentioned that P wave depicts atrial depolarization. So for you to see the P wave, the atria must depolarize, and therefore, if it doesn't depolarize, normally then you will not see the P wave. So examples of no P waves are when you have atrial fibrillation. Atrial fibrillation, you only have fibrillation wave, no P waves, because the heart, the atria does not contract as it were in the atrial fibrillation. It's only fibrillates, it's like shaking, all right? And then, so in addition to the no absence of the P wave in AF, the RR interval is irregular. Secondly, if you have a junctional rhythm, when the rhythm, instead of arising from the SA node, is arising from the AV junction, also you will see a P wave because there is abnormal initiation of impulse. So the impulse has not spread to the atria to cause any contraction and cause the P wave. Sometimes in junctional rhythm, you see an inverted P wave, in which the case the atria are retrogradely depolarized by the junctional initiation of the rhythm. The other causes of no PUA is when you have sinus arrest, of course, when the sinus node refuses to discharge, or you have a sinus atrial block, or you have even a systole when you have complete line, there is no discharge from the SE node. Then finally, you have hyperkalemia severe, also have absent PUA. I'm going to show you pictures of some of these things in the next slides. So if you have total P wave, it's usually showing that it's enlargement. If you have broad notch P wave, it's enlargement. If you have biphasic P wave in V1, it's also showing early enlargement, the so-called modus index. So this is a slide that shows you atrial enlargement, and you see that the P wave is M-shaped and notched here. It's broad. Normally, the P wave is also the size is like a square circle. It's 2.5 millimeter by 2.5 millimeter, not more than that. So if you have a P wave that is broader than that and notched, it's likely because of left atrial enlargement, and it's because it takes longer time for the atrium to be the initial arm of the P wave is formed by right atrial depolarization, and the later arm is also is because of the left atrial depolarization. So if the right atrium is enlarged, the upper arm will be longer and it will give you a tall peak P wave. While if the left atrium is enlarged, then the upper arm will be normal, and then the lower arm will be longer because it takes longer time for the left atrium to be depolarized, and then you have a broad notched P wave. So it also, this is another thing I mentioned, the modus index. If you have a biphasic P wave in V1, it's also depicts a left atrial enlargement. AF, I'm sure all of us have seen these tracings before. You don't see clear P waves, only fibrillation waves. You also see irregular RI interval. This is atrial fibrillation. Other abnormalities of P wave, you see this is atrial floater. You have the typical sawtooth appearance on the tracing. Atrial floater is usually atrial floater has a regular RR interval, except when you have a variable block. You have atrial floater variable block, then you can see irregular RR interval. This also, the slide down is showing you junctional rhythm. You can see that there is no P wave at all because everything is from the junction. So this is another abnormality of P wave. And of course, asystole, I mentioned that this is already flat line. This one, please look at the patient and do the ACLS algorithm. Now, you can also have inverted P waves. This can be seen when you have displaced electrodes. Also, dystrocardia is another abnormality, and there is depolarization. And you can also have ratios of pitch different in different heart blocks. So this is dystrocardia. You see the R1 is negative. I mentioned it earlier. You see the B4, B5, and B6 are all negative. So this is dystrocardia. So heart blocks, I'm going to go over that fast. I realize time has passed, but these heart blocks, you have type 1, type 2, and type 3. Notice type 1 is a chemical phenomenon. We have progressive prolongation of the PR interval, and then a drop bit. Type 2, some P waves are not conducted, but PR is fixed. And type advanced people, when you have fixed ratio of the P to QRS, we have multiple P's to QRS, and type 3, you have complete dissociation between the P and the QRS. This is an example of the prolonged PR interval for heart block. These are the causes, we jump them. And then this is second heart block, different types. Mobius type 1, you see the progressive prolongation of the PR interval. And then you have a P that is dropped here. And then you have a repeat of the cycle. And the Mobius type 2, you have some P's that are not conducted, but the PR interval is fixed. And 2-to-1 block, you have just 2P to QRS complex and a fixed ratio. And then a high degree AV block, when you have a fixed ratio of the P to QRS, we have multiple P's. In this case, you have 3 P's to QRS complex. And this can easily degenerate to 3rd degree heart block, and we need a permanent pacemaker. Now, third heart block, when you have complete dissociation between the atria and the ventricles. And so you have the atria beating on their own. These are all the atria beating, and then the ventricle also beating on their own. And you have the no relationship between the P and the QRS. This is narrow complex, so this is a supranuclear block, while this is wide QRS, this is infranuclear block. Those differentiate between the two third-degree heart blocks. Then sometimes we have shortened PR, and the typical cause of that is pre-excitation. When you have the impulse, rather than flowing through the normal route of going to AV and get delayed, it pass through an accessory pathway and stimulate the ventricles. And typical example is the WPW syndrome, in which the impulse pass through the bundle of Kent and polarize the ventricles, and you have PR interval is shortened, but in that case, we have a delta wave, which is slowing of the QRS complex upstroke at the beginning. The Q wave, you see that it is a negative Q wave at the beginning, usually of the QRS complex. It can be seen normally in the 1, 3, 2, 3 AVL and the lateral leads, but it's abnormal when it is more than 2 millimeter deep and 1 millimeter wide, or more than 25% of the preceding airway. And this is a normal Q wave. And when you have a deep Q wave, it usually implies an infarction in the pathological. Causes of Q wave are many, but I think transmural MI is one you cannot afford not to mention. It's one of the most important cause of a pathological Q wave. And so I put this so that to show you how the Q wave is produced. Now, when you have an impacted wall of the heart, a lead that is facing this wall will see this as an electrical window, so that it will now, instead of reading the tracing as if it is located outside the heart, because this electrical window, there is dead tissue, all the conducting fiber are dead because of infarction. The lead will read as if it's in the middle of the heart, and so if it's as if it's where it were here, and since it became in the middle of the heart, now all the impulse will be moving away from it will be negative, and that's why you have a Q wave. So Q wave is formed in infarction because of the electrical window that's created by the infarction, and the lead will assume a position of being inside the heart chamber, and the the impulse moving away from it will give a negative deflection and result in the Q wave. So this is an example of anterolateral MI. So the distribution is in V1, V2 up to V6, as well as the lateral leads. But the Q waves here are very deep. You see them? The QS waves are very deep, and we have also ST segment elevation. Next slide is so this is the abnormality. Then arrow progression, normally the R in V1 and V2 are negative, the transition V3 and V4, and then the R and V5 are positive. This is important so that when you see changes in this, then you'll be able to see that there is either poor arrow progression or normal arrow progression, and the causes of poor arrow progression are also listed on the slides. You can read them later. Now, the QRS abnormalities, abnormalities of height, abnormalities of shape, abnormalities of width. I'm not going to discuss that in detail, but just to mention that usually when you have low voltage complexes, you consider things that will move, that will cause a barrier between the chest wall where the leads are located and the heart, and like fat, like air in case of obesity, and COPD or effusion or fluid in case of effusion. And the definition of low voltage is if the whole QRS complex is less than 5 in the bipolar leads, less than 7 in the augmented leads, and less than 10 in the chest leads or the precordial leads. And then high voltage are usually seen in patients with either LVH or RVH or bundle branch blocks or WPW syndrome, or also calibration. And then this is the circular loop criteria for RV. I'm not going to discuss that. And then the causes of LVH and RVH are also listed, so that we can put this in context. That's why I'm given the possible etiologies. This patient was all very low voltage and this, and if you follow this criteria, see that this is usually B1 and transition and B5, and this is positive. So when you have a predominant over S ratio is more than 1, there is right ventricular hypertrophy. So this is abnormality of width. Usually, if you have a problem with root of depolarization, like mechanism of depolarization, like in hyperkalemia, you also have wide varus complex. For the bundle branch block, depending if that is left bundle branch block or right bundle block, you see the M shape left in LBB or the RS pattern. In RBB. I'm going to discuss this because of time. I'm always reach an hour, so I think I need to and this is because somebody with premature contraction, and it occurs earlier than expected, and then the normal beat time, so we have complete reports. Then VT, this is familiar to you as an anesthesiologist because you see a lot of VT in the ICU and the CCU, and it's important to identify VT and differentiate it from SBT with aberration because they both present with wide complex tachycardia. So the differential diagnosis of VT, as I mentioned earlier, is SBT with aberrant contraction, SBT with WW syndrome, or what you call the antidromic AVRT. When you have a pace rhythm, you also give a wide complex tachycardia if you have an artifact or you have metabolic rate like hyperkalemia or other abnormalities. So the features that will give you an idea whether it's a VT and not an SBT with an aberration are: 1, we have very broad varus complexes; 2, we have absence of typical right bundle branch block or LBB morphology pattern. When you have extreme axis deviation, the so-called nodal axis is also indicative of VT rather than SBT aberration. When you have AB dissociation, when you have a captured bit, and I'm showing a captured bit here in this slide, or you have a captured bit here with a normal bit in between the tachycardia tracing, and have a fusion bit when you have a fusion of the tachycardia tracing and the normal bit, and gives you a bit like this. So these are the features that will guide you as to whether what we are seeing on the screen is a VT or an SBT with aberration. Other things are positive or negative concordance throughout the chest lead. When you have either positive or positive concordance, then it's likely to be also a VT rather than an SBT. The other things I want to go into them, but these are simple enough to identify this. So BF, of course, this is a malignant arrhythmia. When you see it, please look at your patient and treat them rather than looking at the ECG. They need to be defibrillated. And then HC segment, I mentioned, is the isoelectric line that is usually consistent with either the PR segment or the TP segment. The TP is between the end of one QRS and the beginning of the next QRS complex. And it's usually lasting 0.27 to 0.3 seconds. The J point is the junction between the S wave and the beginning of the ST segment, and then it represents the end of depolarization and the beginning of depolarization, as I mentioned earlier. And this is the ST segment, and this is the J point on the tracing. I will just jump. This is a tracing to show you how it should be. So this is the ST segment here. This is the segment, and this is a baseline consistent with either the TP or the PR, all right? Now, if it's elevated, it will be above this isoelectric line, all right? If it's depressed, it will be below. So the abnormalities of ST segment is either ST segment elevation or ST segment depression. These are the two abnormalities of the ST segment. And if it is ST elevation, then there are 3 types. It could be downsloping ST depression, upsloping ST depression, or horizontal ST depression. And the J point occurs at the end of the QRS. And all this definition of the deviation is done in reference to the J point, so that you have a clear reference point. The causes of ST abnormalities are also listed on the slides. You have possible ST elevation and ST depression. And importantly, MI, STEMI, there's STEMI and there's NSTEMI, which causes abnormalities of ST elevation, and many other causes, which with of time I'm not going to discuss. You can see them later. And this is a typical slide showing a very severe ST elevation. You can see this the isolated line, and look at the ST segment, how big it is elevated from the baseline. And this is also another one showing in the inferior MI. You see the elevation above the baseline. And then the next one is the pericarditis also causes ST elevation, but there's a difference between elevation from pericarditis and that from MI. The MI is convex outwards, the pericarditis is concave outwards, and the one that is from pericarditis is usually more widespread than MI, which is usually localized to the well affected. And then you can also have ST elevation that is from early repolarization, which is before thought to be a benign condition, but now it is now said to predict certain cardiac death in some patients. So when you see that it's just some small elevation, and usually the lateral leads of the precordial. Then the cerebrocardial ischemia also causes ST depression. You see that it's slightly depressed from the bedline, and is another cause of ST depression leading to other things. The Jackson effect also causes downsloping ST depression, the so-called reverse tick sign. You see that this is a reverse tick sign, you see on B5. This is another cause of ST depression. Then lastly, I'm going to mention a few words about abnormality of T-wave. It will be too tall in early minutes and 2 hours of MI or hyperkalemia. One will be very tented tall T-wave. It could also be too small, like in hypokalemia, in pericarditis, or in pericardial effusion, or in hypothyroidism. The T inversion will be a normal variant in some group of people listed. It will be caused by MI, ischemia, strain, or cardiomyopathy. And other causes of T-wave inversion are also listed on the slides. This slide is showing a very peak tent T-wave in hyperkalemic conditions. See that in B1, in B4, B5, and B6. I apologize for this tracing. QT abnormalities, these are very important because of the long QT syndrome that are form of genetic disorders with some caused by some mutations. But the cause of QT it's not only long QT, other causes like myocarditis, ischemic heart disease, electrolytes like hypokalemia, hypovolemia, hypocalcemia, all cause QT prolongation. Hypothermia and drugs also are other causes, while QT shortening is caused by hyperkalemia, hypercalcemia, hypothermia, acidosis, and other causes. This is a slide with prolonged QT to see. This is the Q and this is the T, so how prolonged with the QT. But don't know that the QT also varies with breathing, so varies with heart rate. So that's why I mentioned you need to use some formulae to correct it with the heart rate. If it is bradycardia, then it could be prolonged. If it is tachycardia, it could be shortened. So in summary, ECG is a simple tool that provides tons of information on the patient. You see that there's a lot of things that we can identify on ECG to help us make a diagnosis of the patient. It's easy to master by reading different ECG traces repeatedly. You cannot master ECG by just being afraid of the traces. You have to look for the traces, read them over and over and over again. And anybody can master it. You don't need to be cardiologist to master ECGs actually. But the only to master is read them continuously. Difficult ECGs are encountered even by experts. So don't worry if you will not make sense of the ECG. I've read a book that the author said he has interpreted 200,000 ECGs in the life over a lifetime, but he still finds ECGs that he can interpret on first looking. So if you can read them, don't worry about it. Even experts have difficulty sometimes. Don't be satisfied by identifying one abnormality. Be systematic and only comment after you have analyzed the whole tracing. Sometimes we are quickly to mention one abnormality. You're saying a PVC, and that no, it's not Eureka yet. So please be systematic. Look at the whole tracing, and you have a complete report. And if the patient is with you, look at the patient, not the ECG all the time. You'll be able to save a life by doing that. As much as possible, describe the ECG abnormalities, and don't jump to diagnostic conclusions. Thank you very much. I appreciate this opportunity to give this presentation, and it's open for discussion. Thank you.
Thank you, Professor Mahmoud Sani, for this very erudite presentation. Basis of ECG. I want to let our audience know that we can drop our questions and comments on the chat block. Currently, we have a few, and I'm going to read them out to our presenter so that he can throw more light on some of the areas that some of the audience could not meet up with. So are you still with me, Prof?
Yes, I'm with you, please. I apologize. I had to go fast. The last time was too small for the presentation. I think it's live, but
all right.
Yeah.
Thank you for the presentation. Please let once the NSO want to let us know that this slide the presentation will be available on our YouTube channel, because there were some comments about Prof being fast. You agree with me that ECG is a very, very volatile topic for most people. So really, I'm sure some of us will need to go through it again after this presentation. We get a better grasp of what you have presented. Thank you, sir. So I'll just take a few questions here. The first question I have here from the chat box is, how do we identify SVT? So I'll just read them out so that you can comment on them later. It says here, how do we identify SVT? Then a second question, kindly explain the 3-lead analysis for cardiac axis identification. That's the second question. Then a third question, can we differentiate between Mobius type 1 and Mobius type 2 second-degree heart block? So these are the 3 questions for now, sir.
Okay.
If you have questions, we can put them on the block and we'll pick them and give them to the presenter. So while he's addressing these ones, I'll check the chat box for other questions. Thank you, sir.
Okay, so the first one is the issue of, let me take time with that's what the Mobius type 1 and type 2. Both are forms of or types of secondary heart block. And the Mobius type 1, where we have the Wenckebach phenomenon, and how you identify it is the progressive prolongation, okay, of the PR interval. So with the first QRS complex, you may have a PR interval of 0.2 seconds, and then the next one is 0.24, the next one is 0.30, so they're getting prolonged. And then the Q wave, then the P wave is not transmitted, meaning you have a Q wave that is dropped. So you don't have an ventricular activation following an atrial contraction. And so the cycle is repeated. You have another P wave, now P wave back to PR interval 0.2, and then it's repeated. So this progressive prolongation of the PR interval with a drop of a P wave and then repetition of the cycle is the Mobius type 1. The Mobius type 2 is when you have the PR interval is fixed. It's not prolonged, it's not progressively prolonged. However, you have a P wave that is not conducted. All right? So that is a Mobius type 2. So it's fixed PR interval in all the tracings, but you have an unconducted P wave. This is also from the 2-1 block. 2-1 block is also fixed PR interval, but instead of one P that is not conducted, you have for every QRS complex, you have two atrial contraction to one ventricular contraction. So that's 2-1 block. So this is the 3 types. And of course, you have the high grade or advanced AD block, in which you have usually 3P QRS in a fixed ratio. And this, what I say, can be generated to a 3rd-degree heart block. and may need a permanent pacemaker. Now, the 3-lead analysis, is when we use lead 1, lead 2, and 3, eyeballing them to see what is the predominant deflection on those leads. And in a normal, if somebody with a normal axis, the 3 analysis, with all the leads will be positive, but the 2 will be the one that is predominantly more positive than the others. Okay, there is somebody with left axis deviation, lead 1 will be positive, and lead 2 and 3 will be negative, but the 3 will be the predominantly negative of the leads. And then in the last one, the right axis deviation, in which the resultant vector is towards the right side of the heart. In that case, lead 1 is negative, lead 2 is positive, and lead 3 is positive. So this is one of the methods to get the axis. So use lead 1, 2, and 3, and use which ones are predominantly positive and which are negative. Normal axis, all are positive, lead 2 more positive than the others. Lead 2, left axis deviation, lead 1 is positive, the other 2 are negative, but lead 3 is more negative than the lead 2. And then the third one is right axis deviation, in which lead 1 is the one that is now negative, and then lead 2 and 3 are positive, and then lead 3 is more positive than the 2. Then the first question, which is now is identifying SVT. First, I showed a slide of SVT. SVT is a supraventricular tachycardia. The rate is usually more than 150, because between 100 and 150 can be explained by sinus tachycardia. That is fine. So the rate is more than 150 usually. And the second thing is a narrow complex tachycardia. When you see the QRS less than 0.12 milliseconds, that is definition of the narrow complex tachycardia. And then the other issue is the absence of the features that would suggest ventricular tachycardia, basically, like concordance, as I mentioned earlier, like I didn't mention that the RS Brugada sign, you see all of them. And you will not see fusion bits, you will not see the capture bits in somebody with SBT. These are all features of supraventricular tachycardia. So this is how I identify SBT, and these are the responses to these questions. Thank you.
All right, sir. Thank you, sir. I hope those who posted those questions on the blog, they are clear with it. So, sir, we have a few more questions on the blog. One of them is, what is sick sinus syndrome on ECG? Then there's this very interesting question here. It says, if you have an ECG machine that has given you all values, you still need to calculate them manually. Then how do we differentiate the various bundle branch blocks on ECG? Hello, Prof.
Okay. Yes. Can you hear me?
Yes, sir. I can hear you, sir.
So the first one is the sick sinus syndrome. Now, sick sinus syndrome is a situation whereby you have bradycardia alternating with tachycardia. You have a patient that comes to me, and the patient, his rate is 30 beats per minute, and you come next time, you jump just like that to maybe 110 or 120. Usually caused by either degeneration of the sinus node or infarction of the sinus node. All right. So so you have just wide variation of the heart rate, of the pulse rate, and it's because of this degeneration or infarction of the sinus node. And the treatment for sick sinus syndrome is a permanent pacemaker. Actually, with the ECG, you will see sometimes signs. If you do Holter, you see many period of sinus semi-atrial pulses, or sinoatrial block. And if you examine the patient, you find what I mentioned of the variation in the heart rate. And then it's caused by fractional oscillation of the SA node, and the treatment is common pacemaker. Now, most normal ECGs now will give you the intervals. And then, so the pair interval is weighted automatically, and usually it's all correct. Now, so in terms of doing the measurements again, you don't need to do them again. But what we don't like is adopting the interpretation of the ECG. Usually, the normal ECGs put conclusion. They tell you this is anterior MI, or this is something like that. We want somebody who would read the ECG and confirm or not whether what the ECG tracing mentioned is correct. That is one. For things like QT also, the measurement is measured, and some machines don't correct based on the heart rate, but others do. So some machines, you see the QT interval as this, and the QTC is this. So it gives the absolute QT measured, and then the corrected QT based on the error interval. So if you want to use the QTC and your machine do not show the corrected QTC, then you have to do the correction of the QTC. So that is the issue about the calculation. Now, in terms of the, I have a slide on the, but let me just explain the right bundle branch block and the left bundle branch block on the ECG. So what happens is in the right bundle branch block, the activation of the right ventricle is delayed because there is blockage of the right bundle. So normally the activation is from left to right. So the impulse spread from the left part of the septum to the right. And so in a right bundle branch block, the activation is delayed, and then it has to spread across the septum from the left ventricle to the right ventricle. And the activation of the left ventricle in that case is normal because there is no blockage on the left side. And so the early part of the QRS complex in that case is normal. And then because of the delay in the right ventricular activation, you have a second R wave, the so-called R prime, on the right ventricular lead, the V1 to V3. And also the delay causes wideness of the QRS complex. So in a nutshell, what you see on the ECG, on the V1 or V2, it has an RSR pattern on the ECG, while on lead 1 and V6, you have a deep S wave because of the delay in the activation of the right ventricle, which causes widening of the QRS, as well as this RSR pattern. In left ventricular branch block, normally the septum is activated from left to right. And if you do that, you have a small Q wave on the lateral leads. In left ventricular branch block, the normal direction of septal polarization is reversed because the left ventricular branch is blocked. And so you don't have the normal activation from left to right. What you see now is activation from right to left. And so the impulse spreads first to the right ventricle because the right ventricular branch is normal, and then come to the left ventricle via the septum. So the sequence of this activation extend the QRS complex to more than 120 milliseconds. And you don't see the normal Q wave you see on the lateral leads. So you have a wide QRS complex, lead 1, lead V5, and V6 because of the delay in activation of the left ventricle, while you have a deep S wave in V1 and V2. So you see on the slides this description, and then the pattern of the ECG. The so-called William Morrow that it described showing the finding in lead 1 and V6 in the various forms of the bundle branch blocks. So a bit of time, I didn't have time to go through them. I jumped slide, but you see them. But this is the reason. This is the explanation for why you see what you see. The RSR pattern in V1 and deep S wave in lead 1 and 2 in RBBB, and the M-shaped complexes in lead 1, V5, and V6 in the bundle branch block.
Right, sir. Thank you, sir. Another question. There's this question, sir, that you said early repolarization is now considered an abnormality. So can you throw more light on it?
Yeah. I think it's one cause of ST segment elevation. Before now, it's assumed to be a normal variant, a normal finding, a benign thing. But there was a publication some 5 years ago that actually looked at patients, a lot of patients in their tens of thousands with early repolarization on their ECGs. And it's found that when they are followed up over a long period of time, some of them have risk of having some sudden cardiac arrest or cardiac death. So that's why I said I didn't want to just dismiss it as a benign thing. I do want to inform the audience that now you may need to follow up your patients with early repolarization and see what happens to them. At the moment, there is no treatment, as far as I know, for someone that has early repolarization. They're not treated; they're just followed up to see what they have.
All right, sir. Then another question is: do P wave accompany QRS in SVT?
Hello, I didn't get the last question.
In supraventricular tachycardia, is asking, does P wave accompany QRS?
Yeah, okay, so I get what you mean. In SVT, yes, you may see the P wave, but in EVT is completely EVT dissociation. You don't see it. And even the SVT, sometimes if it's too fast, it will be buried. It will be buried in the complex. But you could see the P wave in the SVT. That is correct.
All right. Thank you, sir. I want to encourage every participant here to take a look at the chat box. There are some announcements for us from the Nigerian Society of Anaesthetists. Prof, sir, I want to thank you for the presentation. That is all the questions I have on the chat box. At this point, I want to hand over to the executive of the Nigerian Society of Anaesthetists.
So before you hand over, I want to thank the society for inviting me. I want to apologize for being too fast because I didn't want to spend more than 1 hour at the time. And then ECG is a very big field. If you take any abnormality, you can discuss it extensively, but we have to touch each and every abnormality of the wave. So I really apologize. I will make the slides available and you have the recordings so that people can go through, and also leave my email. If there's anything I can do to participate, I'm happy to do it. Thank you.
All right, sir. Thank you very much, Prof. Well, I appreciate your coming. So, sir.
Thank you very much, Professor Mahmoud Umar Sani, for this presentation. We cannot thank you enough because you've been with us in Kano for more than 15 years, and we consider you as part of us. Thank you very much. I know you are busy and you say you want to even leave earlier. I don't know, but let me call on the President NSA to take over from here. Thank you. Madam President, please. Okay. So maybe she's not here. So I want to recognize the presence.
Can I leave?
Hello? Yes, you can. Thank you, Prof. If you want to leave now.
Okay, thank you.
I know you're very busy. Thank you so much. Thank you. We are grateful. Thank you. General Shina Ogumbi was here much earlier. If you are around, sir.
Yes, thank you so very much, Professor Dati.
Yes,
that was a very good presentation, which I can title ECG Made Easy by Professor Sani. I want to join you and every one of us members of the NSA to say a big thank you to Professor Sani for this presentation today. Thank you. Well done.
Thank you, sir. There is a president of SAM, Society of Specialists in Airway Management, faculty chair with African College of Surgeons. Oh, I can see the president. Please do take over from here. I just want to recognize our very senior colleagues and also our friends from East and Central Africa. I can see Dr. Ndaba Sipuka. Madam President, please. Thank you. Dr. Briggs, you have to unmute. Can you hear me? Okay, any of the people I mentioned? Oh, okay, go ahead, thank you.
Yeah, I'm sorry, please, for that little delay in my response. I must say thank you so very much to the speaker of today, Professor Mahmood Sani. We appreciate you so very much, especially considering your busy schedule, for this excellent delivery. You have truly shown us that you are a generous teacher, a generous leader, because, I mean, you have also asked us that we can always contact you through your email address, you know, privately. So thank you so very much. You have done so well. Like our general said, General Ogubi, this can be titled ECG Made Easy or ABC of ECG Interpretation. Sir, you have done well. On behalf of the Board of Trustees, the executive, and all NSA members, we say thank you so very much for this love you have shown us as a society. Now, on a general note, I know we all know that ECG is a very essential tool for us in our armamentarium. We are perioperative physicians, as you all know, and therefore, we need ECG in all our practice, mandatory in our monitoring for all anesthesia, irrespective of type or situation. And also as critical care physicians, ECG is very mandatory. You have to know how to read your ECG while in the theater, while in the ICU, before you call on the physician. So this is a very good one. And I want to thank the chairman of the Education Committee, Associate Prof. Deti, for putting all this together. Thank you to every one of you that has made time to be with us here today. We appreciate you and we promise you that we will not fail you. We'll ensure that we give it to you. ECG, again, is one subject I know it said both the teacher and the examiner always look through again the night before the exams. So thank you very much to every one of you. I'll hand over now to Dr. Deti to tell us the next subject and date. So on that note, Dr. Deti, please, Chairman Education Committee, thank you so very much. Before you speak, let me thank the technical committee, Emeka. Emeka, thank you so much for hanging on and ensuring that everything works out on the technical side. Thank you. Dr. Deti, please.
Thank you very much, Madam President. Well, the next topic, for next week will be on it's something similar that we need in our practice, interpretation of radiographs images. So it will be an exciting one as well. But again, let me tell you well ahead that it will be the day, it won't be on Saturday, it will be on a Sunday. As you know that Saturday, around this time, voting will still be ongoing in many areas. So that is the only adjustment to the time, okay? And then many people are saying that recordings and so on, it will be available and it will be uploaded. Someone said that he's thanking us, thanking the speaker and NSA that we are making his practice very, very interesting in a village somewhere in Anambra State. That is what we want. Thank you very much. So thank you very much. Our teachers who are here, I don't know if anyone wants to speak before we sign off, but in the absence of that, I want to say thank you and see you next week. Thank you very much.
Yes, before you sign off, Dr. Deti, I would like to say Dr. Ngbemena has been so excited with our presentations. I think he's going to present anesthesia in the village setting to us one of these days.
Noted.
So Dr. Ngbemena.
Yeah, I will get in touch with him. Thank you.
Yeah, so thank you everyone.
Please, thank you everybody. I'm enjoying
yes.
it. I don't like it. I don't like listening.
Yeah.
It's difficult to find this kind of thing from doctors.
Yeah.
So I'm enjoying it.
Great.
Thank you. Thank you, Dr. Ngbemena. May I say that all this, of course, money is the fuel that oils the engine. So please ensure you all pay your dues so that we can keep moving on and satisfying you according to the mandate you have given us. Thank you, everyone, and have a lovely evening. Have a lovely weekend. Goodbye. Thank you.